So I've got with me Associate Professor Michael Stubbs, specialist in oral medicine here today. And one of his specialties is in dental sleep medicine. He teaches at La Trobe University at the undergraduate dental program and working privately at the Epworth Hospital in Melbourne, in East Melbourne. We're lucky to have you here today, Michael. Thank you very much for talking to us.
Thank you. Right.
Let's kick things off. First of all, mate, do you want to tell us a little bit about yourself?
Yeah, look. Oral medicine is a interesting specialty of dentistry. It's not commonly practiced. A lot of people think that oral medicine is all about giving medicine orally, but we do a lot more than that. We actually come from and originate as dentists, and in my specialty, I became an oral pathologist first, and then I did a second specialty training in oral medicine. And I do teach at La Trobe for the undergraduates in dental school, but I do a lot of presentations nationally and internationally. So I keep my hand pretty busy in clinic, but I also obviously enjoy sharing the knowledge.
That's great, mate. I think it's a good balance to have is, when you're seeing patients, most of the week and all day, every day, it's good to, break it up.
Oh, yeah, absolutely.
So how did you get into dental sleep medicine?
Well, when I finished my training in oral medicine in 2002, and part of my specialty involves dealing with patients who have temporomandibular disorder, which is, for a lot of colleagues, they'd know all about jaw pain. And what I found was way back in 2003 when I started private practice, I was getting a lot of patients referred to me who had mandibular advancement splints and had sore jaws. And I kind of really decided at that moment in time that there's got to be a better way of doing it than just simply making a device for a patient who's got sleep apnea and then wonder and deal with the problems as they develop. So I developed my own protocols for treatment. And a lot of those protocols are based on the international standards. But because I took the decision to actually make the devices, advance the devices, teach the patients how to use them, follow them up on an annual basis, it got me really interested in the benefits that we can do for people. Because as dentists, we make a lot of patients happy with a smile and they function better. A lot of us involved in the oral health aspect help patients by making their mouths feel better and, more importantly, helping sustain a healthy body because they've got a healthy mouth. But when you deal with patients who have sleep apnea, you literally can change their life, which in dentistry is a pretty difficult thing to do for a lot of the things we're trained in. And so you have a big impact on the quality of someone's life. And literally someone goes from being tired, irritable, or getting complaints of snoring to suddenly being told, I didn't realise that when I wake up in the morning, this is what normal is. And then as fate would have it, I ended up realising when I saw a lot of my patients that I had the same symptoms other than irritability. And I just thought I'd add that. And I ended up having sleep apnea myself. So the best part was I made my own device. And that was good for me, but it was also a good insight into, how people can feel better with the device. And also I practice what I preach. So that's how I really got into it.
So you're quite passionate about the field by the sound of things, and being a patient yourself, you understand the challenges of compliance with the treatments and what is involved in getting yourself to a place where you are starting to feel better and the treatment's really working for you. So you have that unique perspective as well, which is also great.
Yeah, and I think the other thing too is it's led me to doing a lot of interesting things on the side. I mean, I'm involved in the development of a trial device, which we'll talk about certainly in the context of future talks. Also, I'm developing at the moment a compliance device that will fit in these devices to see if we can get, compliance so we can measure the number of hours patients use them. Because a lot of sleep physicians are still wary of the fact that they'll say, yeah, the patient has CPAP. We can monitor how many hours they use it because it's recorded. But how do we know if the patient's wearing the dental device? And the answer is there are some pretty clever ways to measure this. And one of them is one we're developing at this moment in time. And that's all evolved just from my own clinical experience and talking to other people who have the same passionate interest in sleep medicine.
Yeah, so that kind of leads into the next question pretty well, I guess, as well, is where do you see dental sleep medicine heading in the next 5 years? And I guess, what you just described is the unique digital experience that a patient on CPAP, might have. And that experience traditionally for dental sleep medicine patients has been, not to the same level because we just don't have that monitoring, remote monitoring capacity for oral appliances. But where do you see dental sleep medicine heading? And I guess as a subsection to that is, technology-wise, where do you think things can head over the next 5 years?
Well, I think, look, in 5 years' time, a lot of dental disease, let's face it, in the Western countries is reducing because people are more aware of their oral hygiene management. They go regularly to the dentist, or a lot of people do. And so the incidence of restorative work is reducing. There's a lot more interest in cosmetics, dentistry, and aesthetics and so on. But not every dentist wants to just do that. And I can foresee that in the next 5 years, dental sleep medicine for some practitioners will represent about 20 to 30% of their business, because it's a very innovative way of treating a patient, understanding the oral upper airway and how you manage their oral health, and also manage the device itself. But even better than that, I think you have the opportunity to learn more about the managing of these people and make yourself unique in your area of the profession. So in other words, if you have a particular interest in dental sleep medicine, maybe other colleagues in your area don't, you may be able to initiate, referrals of patients by people knowing people, or colleagues in other health areas referring to you for the treatment of the patients. And it's actually quite, I think, a novel and innovative way of expanding your practice.
20 to 30%, mate, that's a big call. I think, that if it really does go in that direction in the next 5 years, it's a big change. And I think, we don't need to have these, particularly dentists, I don't think need to have these limitations around, whether they can or, they have the confidence, or, they can or can't do, these sort of things, because really the technical skills involved in treating sleep apnea, I think, they're easily learnt. And, it's up to, the individual to, I guess, get upskilled. But the technical skill in terms of making the oral appliances, do you see that learning curve if, somebody doesn't have experience with that being quite low, or do you think that, that still does take some time and some work?
Oh, look, it takes time, like anything that we do, anything new. Every dentist knows how to take an impression. I mean, a lot of colleagues now are using digital scanning technology as well. But even so, it's one thing to know how to do something. It's quite different to actually doing it well. And part of the idea of teaching dental sleep medicine in this concept is to actually enhance your abilities to know what to do and how to deal with issues, particularly if something doesn't go quite as you would plan it to do, knowing how to resolve those problems. And I think also, when I said 20 to 30% of your practice, I think the reason I can say that is if you look at the population studies, depending on which part of the world you're referring to, in the US, for example, 25% of men and 16% of women have obstructive sleep apnea. Of those, probably only 1% of that population are treated because they're diagnosed. In Australia, it's about 16% men and about 12% women. Again, only 10% of our population, or 1% of that particular range of age groups, or incidents, I should say, is actually diagnosed and treated. So there is an enormous potential for the recognition by medical practitioners to treat diabetes, heart disease, stroke risks, or stroke patients who have coexisting sleep apnea. And you'd be surprised the amount of patients that actually exist that you're probably already treating but don't know they have sleep apnea.
Just by training them and picking them up as they come.
Yeah. That's right, increase the incidence. That's why we talk about things like in your medical history forms, have a box that says, do you use CPAP? Because if they say yes, they've already been diagnosed, they might not realise that a dental device exists, which is a good alternative for them.
That's a good point. And they might not be using their CPAP anymore. Might be stored up in bed and they're not compliant and nobody's ever followed them up. So,
That's exactly right. Yep.
that's a great segue again, mate, to you're doing this well. How effective are oral appliances? I guess the biggest question that we get from specialists and referral partners is, well, why would I refer for a patient to receive an oral appliance as opposed to CPAP or other modalities of therapy?
Well, it comes down to the basics, really, which is you pick your cases. I mean, not every treatment's right for every patient, but if you have a look at the studies, and they're out there, they're available to be accessed online. If you have mild severity sleep apnea, which means you basically stop breathing or have laboured breathing between 5 events and 14 events an hour, the dental devices, 90% will resolve that apnea. And if you have moderate severity, which means you stop breathing between 15 events and 30 events an hour, you're looking at a 60 to 70% resolution of the apnea. And if you have severe apnea, which means more than 30 times an hour you stop breathing or have laboured breathing, you're looking at about a 40% resolution. Now, sure, that's not comparable to CPAP in severe apnea cases, but surgery is only 40% success for severe apnea. And I don't know about you, but I'd much rather have a device that I can take out in the morning than having my tongue reduced in size and my soft palate shortened, because I want to try and reduce the apnea events without having any other form of treatment. So dental devices work. SomnoMed have published quite extensively in their own devices, in studies, double-blinded, I'll correct that, in random controlled trials, which show the benefits of the dental device versus CPAP.
That's great, mate. I think that, like you said, the amount of research that oral appliances have behind them is increasing over time, and we're getting more information about how it also works for groups in like snoring and UARS. Can you tell us a little bit about how you would treat a patient who is a primary snorer or suffering from upper airway resistance syndrome?
Yeah, well, I think the first thing is, the critical factor is more about recognising, do they have just noise pollution, snoring, or do they also have an airway issue? And one of the reasons I was really interested in the Night Owl was it's a great screening tool, level 4, which helps differentiate those patients, whether they are simply snorers or they may have an airway issue. And in those cases, what we would aim to do is to try to establish a diagnosis on if there is an airway issue first, which we would call sleep disordered breathing, and that encompasses upper airway resistance syndrome, obstructive sleep apnea, which is stopping of breathing for more than 10 seconds, and or looking at hypopnea, which is the reduction in airflow and by about 30 to 50% when they're breathing. And by having that qualification, i.e. the sleep study results, you're then in a better position to make judgment calls about what's the best device for the patient or treatment. Is it dental? Is it CPAP? Is it one or the other or both in some cases? So when we look at a primary snorer, if someone came and saw me, and usually snoring is the big motivator for people coming for treatment, the first question you want to ask them, which I'll go through in the presentation on how you can screen your patients, is some simple questions you ask from an international questionnaire standards. And then you can also have a look at their upper airway anatomy. I'm going to show you how you can use some radiology to make some judgment calls. Does the patient have apnea or not? And then I think integrating the Night Owl will very quickly differentiate snorers from apnea. Those ones that are simple snorers, dental device works exceptionally well. In fact, in about 90% of cases, you'll resolve the snoring. In the sleep apnea patients or upper airway resistance syndrome, the dental devices work in about 100% of cases with upper airway resistance syndrome, and they'll work depending on the severity of the apnea based on what I just indicated, 90%, 70, 60% success, or 40% depending on the severity, mild, moderate or severe. So it really comes down to having an opportunity to recognise that the patient may have an airway issue, and then appreciate that they need to have some screening tool or some screening mechanism to work out which one needs to have a sleep study and which ones don't. And then you proceed forward.
So it's really, I think, a key take-home message from what you're saying is it really is important that you have a few tools up your tool belt to be able to treat and differentiate your patients into different baskets and groups. And a lot of the time you will get patients that have just been referred to you directly as well. The more experience you get, the more comfortable that treating physicians will be to refer a patient, directly for an MAD. My last question before we get into your presentation is you do see a lot of patients suffering from sleep apnea, and probably somebody that's seeing a higher load than typical dentist would in this field. I guess one of the key business questions that dentists will ask us and are interested in, and our followers are interested in, is how do you get those referrals, and how do you approach referral partners like sleep physicians, and kind of what other professions would you potentially receive referrals from for treatment?
Well, I think the first thing is having the confidence in yourself to be able to treat the patient is goal number one. And then goal number two is going out and meeting the colleagues. Now, you should target, yes, sleep physicians, but you should also be targeting cardiology and ear, nose and throat, because again, cardiology deals with cardiovascular disease, and there's a very strong association with sleep apnea in a lot of the different cardiovascular disorders. But ear, nose and throat as well, because a lot of patients will go to see an ear, nose and throat surgeon for snoring. They may have had a tonsillectomy. And again, the ear, nose and throat surgeon, it's good if they know they can refer a patient off to you to make a dental device, is actually preferable than in many cases doing the surgery. And it's interesting too, because some ear, nose and throat surgeons like doing surgery for sleep apnea. A lot recognise that it's got its limitations. And so my advice to you would be, once you've accomplished the basic tools and confidence in yourself to treat these patients, go out and introduce yourself to those specialty groups. You also want to target the general medical practitioner in your area. And so look at where you practice, identify major referral centres such as major hospital, perhaps some specialist centres, and go and say hello to these people. That actually goes a long way for the colleagues to actually know that you exist. I think goal number three is to develop a practice where you can say to the patients that are referred to you, or you can even say to the potentially referring colleagues, look, I can make the patient a trial device. It's relatively low cost. We can get some validation via a sleep study if that's what's warranted, or we can actually make the device, make sure the patient's comfortable, make sure the patient feels a positive outcome, and then they can go ahead with the customised device based on that confidence. It's a bit like CPAP. A lot of sleep colleagues refer for CPAP because in Australia, and I suspect perhaps in other parts of the world, colleagues can get their patients to rent a machine for maybe a month and do a trial. And if it doesn't work, they're not happy with it, no problem. They move on to another treatment. When it comes to custom dental devices, it's an investment for the patient, and they obviously want to know it's going to work before they spend the money. And so I would encourage you to be using trial devices, and I'd encourage you to make that known to those potential referring colleagues.
Yeah, and that's an interesting point as well, as I think, we as much as oral appliances have been available for use for many years, I guess we're still trying to figure out, what the best model is in the patient care. And actually, the aim of the game really is to incentivize the patient to get on treatment as quickly as possible, because the earlier that they are put on treatment and are compliant with the treatment, the more likelihood of success for us in getting them, to an acceptable standard of AHI and other objective measures that we're looking at.
I think the other thing too to mention there is that there's also a thing called repeat business. Yeah. I mean, dental devices probably last, custom ones, maybe 3, 5 years, maybe 7. Each one of mine's lasted me 7 years. And the reality is those patients will come back for a remake. So you can practice or develop your business model based on remaking of existing patients that you've already treated, plus new patients coming on board. And so you can very quickly see how you can increase the numbers of patients you're treating over maybe a 5 to 7 year period. And so you always remember that there's the remakes of devices as well as the new patients you're treating.
Yeah, that's a good tip. All right, mate. Well, thanks so much for answering my questions.
So let's talk a little bit about what clinical features can you use for patients. How can you assess somebody that sits in your dental chair that may have sleep apnea or may just be a simple snorer? What would you look for? How could you address risk factors? And in particular, how can you just chair side make some judgment calls about, does this patient need treatment or doesn't this patient need treatment? Does this patient need a referral or don't they need a referral to a sleep physician? And I'd like to share with you some a practical approach that you can do every working day of your life. So this is an example of a mandibular advancement splint. Now, we all know that with the mandibular advancement splints, the approach is going to be very much about advancing the mandible forward, which therefore pulls the tongue forward. We also know that from an anatomical perspective, that by doing so, we activate a lot of the genioglottal muscles and the higher glossal muscles, which causes the tongue to want to come forward. It also stretches the palate-glossal and palatopharyngeal arch or folds. And so we do get some stretching of the soft palate and enlargement of the back of the throat, which we call the oropharynx. This device here, you can see, has a block, which is actually, you can see a screw mechanism. This is a Somnomed device. And you can see here, there's a fin here. So why is this separated? Because it just demonstrates that when we make a device for a patient, we don't set the device at the maximum 100% starting position. We usually start them at about 2/3 of their maximum advancement range. Now, again, in the introduction to dental sleep medicine program that we're going to be releasing soon, I'll be teaching you how to review a patient, how to fit a device, and what to look for, and how to treat your patients as they go through the time frame wearing these devices. At the moment, this is just an opportunity to show you the mechanics of the device and the principles with which we aim to achieve. So we know that, in fact, that with regards to the device, you can see in this case here, this gentleman has the normal centric occlusion. And when he has the device in his mouth, the chin is forward because he's advancement. You'll see I've written here as a predictor of success of Biomax advancement surgery. Again, you know, in the introductory course, we're going to talk a little bit about other treatments than just dental devices. And one of them is the Biomax or orthognathic surgery, which in some cases is used for patients to help reduce snoring or sleep apnea. We can often use these dental devices as a trial process, even the custom ones, to see if in fact that potential surgical procedure would be successful or not. You can imagine a scenario of a patient who's got sleep apnea. They have orthognathic surgery, have their mandible advanced, and at the end of all that orthodontic and oral surgery treatment, perhaps 18 months to 2 years, they still snore. Nobody's happy about that. So this is an opportunity, again, using the customized oral appliances to actually advance the mandible and get some concept before they proceed down that path. Most patients, you'll find, are generally quite comfortable just to wear the dental device and have it replaced every 3, 5 or 7 years. So when we talk about evidence-based, and that's important, isn't it, in what we do professionally, everything we do in dentistry is evidence-based, or it certainly should be. So the materials you use, whether you restore a tooth, you use a crown, what cement you use, why do you use a certain type of polishing paste, why do you recommend certain bleaching products for whitening of teeth, why do you recommend certain toothpaste? It's evidence-based background, the literature, the science behind it. And in this context here too, we can see that when you use these dental devices, in real terms, what we're doing is we're stabilizing the lower jaw, the mandible, relative to the hyoid bone. And so it prevents the tongue from trying to flop back, which we say distalize. The mandible is held obviously forward and slightly downward. And we do get some stretching, as you can see here, of these relevant palatoglossal and palatopharyngeal arches. And that's important because when we talk about snoring, one of the things we're trying to do here is stop the tongue from vibrating against the hard palate. In this case, you can see a lateral ceph, and you can see some arrows pointing to the relevant parts of the airway. We know that the airway behind the nose, which is commonly known as the nasopharynx, where the soft palate is, it's called velopharynx. Oropharynx, which of course is the back of where the tongue is, and hypopharynx is lower in the pharynx. And these all three areas particularly are affected when you fit a device, as you can see in this image here. This is a Somnomed classic design, they call it, device, hence the metal attachments on the teeth, which is part of the device when they fit it in their mouth. And what we do is we understand too that when we interview our patients as part of the process of speaking to them, we can actually ask them some pretty standard questions which are based on questionnaires. Now, this one I'm showing you here is called the Epworth Sleepiness Scale. It's not a real measure of apnea, but it's a measure of tiredness or sleepiness. And you can see here that there are some gradings of the scoring here. You've got never, slight, moderate, being a score of 2, and severe is number 3. And as you ask these questions, you say to the patient, you know, when you're sitting and reading, do you feel tired or would you fall asleep? Never scores 0, all the time scores 3. Watching television at night, do you tend to drift off to sleep quite easily, miss the end of the movie? Or do you find that in fact you stay quite alert for the end of the movie or what you're watching on television? 0 for never, 3 for all the time. Sitting inactive in a public place. Sometimes patients just sitting on a bench or having had lunch, particularly a glass of wine after lunch. They might start to feel incredibly sleepy or tired. Dare I say, even in lectures. The worst time for a lecturer to present a course is after lunch, because most colleagues that attend have had a great lunch, and then the weariness in the eyes start to droop. And so we know that from the tiredness point of view, these simple questions that you can score, you add the score up, and we therefore know that based on this scoring, we can get an idea of their tiredness. Now, this is an international measure. It's a good one. It's got some good reliability to it. You'll see it says here 0 to 10, meaning normal. That means if you add the score up, if someone's got 8 or less, and we would suggest to you that even though the sleepiness score says 0 to 10, it's really, I think 0 to 8 is normal. I would argue that 8 to 15 is more mild sleepiness. But when you add the score up, you can get an objective measure straight away. And you can say to the patient, well, you know, based on this international scoring mechanism, it suggests that you do have tiredness more than the average person. We can also use this one called the Stop Bang questionnaire. Now, this is an advantage because it's easy to remember, stop bang. But what it means is the letters of this word denote the 8 variables that you're going to use as in questions. Snoring, do you snore loudly? Now, please remember that a lot of patients are in denial that they snore. It's usually their partner that is the one that will validate that answer. Tiredness, you know, do you feel tired when you awake in the morning, unrefreshed? Again, you know, lifestyle factors. Sometimes people go to bed late. Sometimes patients always get up early in the morning. It may just be they don't have sufficient sleep. The relevancy of asking the tired question is you are recognizing that they have symptoms of weariness, and that might suggest that they have obstructive sleep apnea or what we would say sleep disordered breathing, an airway issue. Has anyone ever witnessed them apnea or stop breathing? You know, sometimes patients' partners might say they gurgle or they lie there waiting for their partner to start to breathe again. That would be deemed as a witnessed apnea. Do they have blood pressure problems? How would you know that? Well, have a look at the medical history. Hopefully the patient's indicated the medications they're taking. And you know, with patients who have hypertension, if you have somebody who indicates that they're on 3 different medications for blood pressure management, it's almost a dead certainty that they'll have underlying obstructive sleep apnea. Body mass index. So in other words, as a person, relative to your body weight and height, do you actually have, or are you deemed overweight? Now, please remember, folks, that patients don't have to be overweight or fat to have sleep apnea. I'm as skinny as a stick and I've got sleep apnea. And teenagers who can be thin and have thin necks can have sleep apnea. But again, it's a judgment call. The age of the patient over 50, what does that really mean? Well, it means if you've got a 60-year-old in your chair, the probability of them maybe having sleep disorder breathing is much higher perhaps than a 20-year-old. Remember, that's not something in concrete. It's an idea, it's a recognised risk factor. And neck circumference. Now, I'm not suggesting that you get out there and get a tape measure and measure their neck. But if you have a male patient, you might ask them, what collar size do you wear? So, for example, if you have a 40 centimetre or 41 centimetre width of neck or greater, that is deemed as a risk factor. Why? Because men, more than women actually, store fat, adipose tissue, in their neck. That's why, for example, patients who have a high BMI have narrow airway. And G for gender, male gender, again, it's probably not necessarily an absolute, because women can have sleep apnea or sleep disorder breathing issues as well. But again, it's a risk factor. So when you add this up, if you have a patient, let's say, who has more than 4 or possibly 5 of these factors, then you can see how the risk of potentially having sleep apnea comes into vogue. And that's what lends itself then to the screening tools that exist that we can use, either a night owl, which is a convenient way of measuring the patient if they have apnea or not, certainly simplistically, but it works, or you might consider referring them off to a sleep physician or the patient's general medical practitioner for a formal testing, which we call sleep study. And again, we'll talk more about that in future talks. And this one is an important one too. It's called OSA 50 screening questionnaire. Now, the reason I say that is the evidence is quite strong that the stop bang that I've just gone through is more applicable to men than women. And I think if you have to agree with that, because when we looked at this one, here we had male gender as a risk factor. In women, this one is where one asks the waist circumference, usually around the lower end of the abdomen where the umbilicus is. You can ask the question, has the patient snored, which has bothered other people? And you can see that when they say yes, they get a score of 3. If they say no, it's 0. Has anyone ever noticed you stop breathing? Again, 2, yes, or score of 0, meaning no, they don't necessarily stop breathing once it hasn't been witnessed. And over 50 years of age, again, score of 2 if they're over 50. Under 50, they get 0. And again, you add this up. And anyone who has a score of over 5 actually is deemed to have risk factors for possible sleep apnea or sleep disorder breathing. So that's the first part, isn't it? Just simply asking some questions. But then we can go on further and you can have a chat to your patient, have a look at other risk factors. And I'd like to share with you some things that you can note chairside in your patients every day of your working life. And these simple things that you're going to look at are indicators of risk for sleep apnea. It doesn't mean they have sleep apnea, but again, if you start to join the dots and look at all the different factors and you start to link them together, evidence of tiredness, evidence or reporting of snoring, reporting of weariness or witnessed apnea events or stop breathing, and then you look at their facial features, the airway volume that they have, what the back of their airway looks like, you can very quickly discern which patients you should be either considering further management in, or those patients that you think probably don't have a problem. Retrognathia. Patients who have small mandibles, one of the reasons for the fact that they tend to have certainly snoring, but even sleep disordered breathing issues, is because the steepness of the mandibular plane here, or the body of the mandible, means their tongue sits further back naturally in their airway. And so for a lot of these patients, having their mandible advance forward with a dental device actually significantly moves their tongue forward and therefore opens up the airway quite significantly. But wait, there's more. You can do a radiograph. Now, a lot of us as dentists will take radiographs. Sometimes we do lateral cephs as part of an orthodontic workup. The value of the lateral ceph, although it's not a measure of does a patient have sleep apnea, but there are some very interesting studies that have been published over the last 15 years looking at risk factors associated with measures that you can do based on looking at your lateral ceph of the patient. And again, I'd like to share with you just some of them. We all remember it from dental school. For those of you who can remember that particular event where we used to trace the lateral cephs, and you remember the landmarks, sella turca, nasion, A and point B, which represented maxilla and mandible, mandibular plane, hyoid bone, length of the soft palate from the posterior nasal spine to the tip of the soft palate, the width of the airway space we call superior airway space and posterior inferior airway space. These all have determined measures that are considered to be averages in the population. And the reason they're interesting is because there are three main measures I would recommend that you might look at for every patient that you happen to have a lateral ceph of to see if there are some radiological risk factors for sleep apnea. One of them is the distance that you measure between the mandibular lower body of the mandible and the hyoid bone. Now, the average length for most patients, we might say, who don't have necessarily sleep apnea is 18 millimeters. So what that really means is that if you happen to measure this and you find that it's 20 or 21 millimeters, it usually indicates that the mandibular plane here is quite steep. And therefore, as I mentioned earlier, the tongue sits quite posteriorly. And what happens there? Well, of course, the tendency for that tongue to either vibrate against the soft palate or the risk factor for obstruction or narrowing of the airway is much higher than a patient who doesn't have 18 millimeters, more than 18 millimeters distance between the mandibular plane and the hyoid bone. Again, it's just one factor, but it's an interesting one. What about, for example, the length of the soft palate? Does anyone actually know what they are? Well, yes, I've written them down here for you. You can measure the length of the soft palate from what we'd say is the back of the nose, the posterior nasal spine, to the tip of the palate. And it usually shows up as a long, almost like a concave type structure or image. And 34 millimeters is considered to be about the average length for a male and 32 millimeters for females. Again, if a patient has 36 millimeters and they're a male, that is also considered to be a risk factor for sleep apnea. Studies have shown, such as this one here I've listed, where the longer the soft palate, the more likely it was associated with patients who had obstructive sleep apnea. Now, again, remember, these aren't indicators that the patient has apnea, but they're useful tools that you already have access to that you can measure on a radiograph to justify an argument, does this patient need further treatment or not? And if I can then continue, if I can get the slide right. Here we go, the thickness of the soft palate. Now, this is the last of the three. The thickness of a soft palate is useful too, because this study that you can see here was based on a Brazilian study population, where the purpose of it was really to see what, if they were able to screen patients cheaply using a lateral ceph to determine those that could get access to a sleep study, formal sleep study, because of the limitations in what was available to them at that time in Brazil. And what they found was, again, length of soft palate, greater than 34 for men, greater than 32 millimeters for women, the distance of the hyoid bone to the lower border of the mandible being greater than 18 millimeters, and the thickness of the soft palate, normally between 9 and 12 millimeters on average, being thicker than that, was also considered to be another risk factor for sleep apnea. And if you look at all three of those variables, you can again start to see how you can start to present a good justifiable argument to the patient about having further investigation. Now, when we talk about obese patients, sadly, a lot of us think of Homer Simpson, and it's called the body mass index. And I think what's important here is that if that gentleman that you can see in this image here sat in your chair, I think it's a fairly reasonable assumption that this gentleman would snore. And I think it's also a pretty reasonable assumption that this gentleman would have some sleep disorder breathing issues. And we know that, for example, with regards to body weight, if you are trying to determine, does a patient have a high BMI, body mass index? What's their weight versus their height? Is it considered to be underweight, overweight, or obese? If you determine the height and their weight, whether it be in centimetres and kilograms, you can go online and simply use one of the online calculators to determine the BMI score. So if a patient has an 18.5 BMI or less, they're considered to be underweight. If a patient has between 18 and 25 BMI, that's normal. 25 to 30 is considered to be overweight, and over 30 is considered to be obese. We know that, for example, that with regards to this increased deposition of fat tissue and storage of fat tissue, he's going to have a very narrow airway. He's also going to have, with regards to obesity, the probability of diabetes, heart disease, and certainly I would think hypertension. Male risk factor, as I just mentioned, was a factor, but remember, women can also have sleep apnea. And family history, think of it. We are a template, if you like, or a copy of our parents. Many people who have diagnosed sleep apnea will often reflect on parents or grandparents that were the same. We inherit the anatomy from our parents and subsequently grandparents before them. And so this condition that we talk about, sleep disordered breathing and even just snoring, can be in many regards just an anatomical phenomena. And as a result, patients who don't necessarily are overweight or obese can still have a problem. So pretty much measuring the neck, as I said, you can go to that trouble if you want to. I don't suggest you need to. I think, as I said earlier, you can measure a patient by just simply asking them what their shirt size or collar size is. This interesting picture of the statue of David shows on the right-hand side a very skinny model, and on the left side having been on vacation, probably a cruise, and coming back and whacking on a bit of weight. The reason this is important is that we know that for every 1% in body weight increase, you get a 3% increase in your scoring of what we call the AHI. That is to say, the likelihood or the severity of patients who have sleep apnea. So if you put on 10% weight, you're going to have a 30% increase in the severity of your apnea based on the scores. And looking at the airway, I mean, here we can see a situation where you're looking at the back of the airway, you've got the identifying the uvula, the soft palate, you can see that quite clearly, base of tongue. And we would deem that as quite a normal airway. And in fact, that in itself, you'll notice here you can't see any tonsils, it's just the back of the pharynx or the throat. In this case, we can see large tonsils here. So it's fair to say this person would snore. They'd also most likely be a very slow eater. They'd probably have a probability or a high frequency of sore throats. And again, when we look at upper airways like we do, this is a thing called Friedman tongue position. And the Friedman tongue position is a means with which we can look at the tongue in a relaxed position in the mouth, and we can grade the amount of uvula or soft palate we can see, and accordingly the risk factors for the probability of sleep apnea and certainly snoring. So having a look at this one here, for example, this is slide A. This would be called Friedman tongue position type 1. We can clearly see the arches of the soft palate, the uvula, there's the resting of the tongue, and of course there's also the space at the back of the pharynx. Friedman tongue position type 2, we can't see the end of the uvula, but we can still see the arches. Type 3, you can just see the tips of the arches, no uvula. And of course, type 4, you don't see anything, just the sheet of the soft palate. The rationale is patients who have type 4 and type 3, especially type 4, are more likely to have a probability of sleep apnea as indicated in this slide. We know patients who have large tongues. How do you know a patient has large tongues? Well, because if the tongue sits in the mouth, overlies the occlusal surfaces particularly of the mandibular teeth, it's usually much bigger than the amount of space it has. Again, it's relevant to snoring. It's also a relevant risk factor for obstruction of the airway. And finally, looking at the anatomy, the deep palatal vault, we know that patients who have a very steep palatal vault often have reduced mid-facial development. And as a result of this, the tongue tends to sit slightly further distalized or distal positioning when it rests in the hard palate. And it also indicates that the probability of these patients are more likely to be mouth breathers because they've probably had issues with adenoid enlargement and therefore inability to breathe through their nose. Again, visualizing this photograph and simply looking at the deep or steep palatal vault, again, is a risk factor that you can put to creating an argument or a justification for further follow-up with these patients. I thank you for your time. I hope you've enjoyed this very brief presentation. I'd like to suggest that when we release the various modules in the education program that we are going to present, each case, each module will look at different areas of oral medicine. One will be dental sleep medicine. We're going to create an introductory and then another presentation called a masterclass for those colleagues who are already doing devices and getting familiar with them, temporomandibular disorders and management and diagnosis particularly, and how you can treat your patients. I intend to do another presentation on orofacial pain and particularly determining the differential diagnosis for these patients and what conditions and how you might be able to manage them. And even further than that, there'll be a series of presentations looking at different examples of mucosal disease. And further than that, I'd like to talk about special needs dentistry. That is to say, patients who are on a variety of medications or have medical conditions, what can you do as a dentist to actually help treat these patients safely and, more importantly, have the confidence to know how to manage them properly? Thank you.